Okay, hi everyone. Welcome to the final session of the Psychiatry webinar series. We've got Charlotte here today to talk to us about the Mental Health Act. So over to you, Charlotte.
Thanks, Alexia. Hi everyone, my name's Charlotte. I'm the CT2 Psychiatry trainee working in London at the minute. And as Alexia said, we're going to do some teaching on the Mental Health Act today. Interesting to note that the Mental Health Act is actually changing. We're in the process of changing, but I'm doing this on the one that we're currently using rather than the one that's going to come into action over the next few years, as it's probably going to be a bit of a lag before that one is actually brought into clinical practice. So learning outcomes of today, we're going to hopefully understand a bit more about the purpose of the Mental Health Act, know about the key sections relevant to junior doctors, understand the detention criteria for the Mental Health Act, have a bit of an overview about practical aspects of the different sections, and briefly we're going to touch on the differences between the Mental Health Act, Mental Capacity Act and Deprivation of Liberty safeguards. So a bit of context about why we need mental health law. The law as we have it at present has been developed over quite a long period of time, and it goes back to when we would lock up essentially what society deemed as lunatics in asylums without any care to their human rights at all, or any sort of question as to why we were locking them up. So for all sorts of things that nowadays we would never do. So it's a bit about, as you said, balancing autonomy with protection of rights, making sure that the necessary treatment for patients can be provided legally, ethically and safely, but at the same time safeguarding patients' rights and also public interest. So it gives us a legal framework to treat people when they don't have consent to be treated, or when we deem them to need treatment in their best interests, but also holds professionals and institutions to accountability. So making sure that the duties and powers of psychiatrists and hospitals are quite clearly set out, but also providing legal protection when doctors are acting in good faith. So mental health law in the UK provides a legal framework for assessment, detention, treatment and protection of people with mental disorders, and at the same time working to safeguard their rights. There are, as we've listed here, several different frameworks under which we can treat patients, and each of these has their own sort of criteria as to when you would use them. Today we're going to focus on the Mental Health Act 1983 as amended in 2007. As I said, there is another one that has recently been passed in 2025, but that's probably not going to come into practice for some time. Just to bear in mind, the Mental Health Act, as we're going to discuss today, is what applies in England and Wales, and Scotland actually uses slightly different law. So, as we've said, the Mental Health Act is the primary legislation in the UK governing compulsory assessment and treatment of mental disorders. So this allows detention or sectioning of patients in hospital when they have a mental disorder that is of a nature or degree that warrants detention. And the detention is deemed to be necessary in the person's best interests, or to protect their health or safety, or to protect others. So we've talked about mental disorder. What actually is this? So the Mental Health Act lays out in section 1 the definition of mental disorder, and it's a deliberately very broad definition. And it's listed as any disorder or disability of the mind, which is clearly very vague and covers a whole host of things. And this includes typical mental illnesses that we know lots about: schizophrenia, bipolar disorder, depression. It also includes personality disorders and organic mental disorders. So, for example, dementia. It does specifically exclude certain conditions as well. So it states that dependence on alcohol or drugs, sexual orientation, sexual behavioural preferences, gender identity are not mental disorders, and you cannot detain somebody for these. Learning disability is an interesting one. So you can people with learning disabilities can be detained under the Mental Health Act, but only if their behaviour is associated, the associated behaviour is abnormally aggressive or seriously irresponsible. So you can't detain somebody just because they have a learning disability. And the same sorts of rules applies for substance misuse. So somebody that's dependent on alcohol or drugs, they could be detained under the Mental Health Act, but not just because of their dependence, only if they had a resulting mental disorder because of their drug or alcohol use. And importantly, you don't actually need to have a specific diagnosis. So we don't need to know for sure that somebody has schizophrenia or somebody has depression. We just have to believe in good faith that this person is showing signs of a mental disorder. So the Act lays out principles under which we should be using it, and these are laid out in the Code of Practice. And these are the key headlines that the Act talks about. So the least restrictive option is something that is talked about quite a lot in clinical practice when we're looking after detained patients. And effectively, this just means that we're using the minimum restriction necessary in order to achieve safe and effective care. And what this looks like practically is, say, for example, you are treating a patient who's detained under the Mental Health Act, Section 2, maybe on an eating disorders unit. The least restrictive option as part of their treatment plan might be that they have a meal plan to follow at a certain time of day, so at lunchtime, for example. That would be the least restrictive option, that you would offer them food. If they were unable to eat the food, you might offer them a supplement as a slightly more restrictive option. If they declined the supplement, you would offer them an NG tube to give the supplement via the NG tube. And if they declined that, then you might have to restrain them and deliver the supplement via the NG. So you can see how you will always try to use the least restrictive option possible, but it does allow you to use more restrictive options if is so required. Empowerment involvement is about involving patients in their decisions about their care. Respect and dignity goes without saying, treating patients with respect, being sensitive to culture, religion, gender, sexuality. Purpose and effectiveness. So any use of the Act must have a clear therapeutic purpose. You should, if you're detaining somebody under a section of the Mental Health Act, you should be able to say clearly what the treatment goals are and expect that they should be effective. And finally, efficiency and equity. So this is about using the powers fairly, lawfully, and without discrimination, and ensuring consistent and timely application of the Act. This is an interesting one. So we obviously should be using the Act without discrimination. Statistics show that that's perhaps not the case. We know for a fact that, for example, Black and minority ethnic groups are detained much more commonly than others, which suggests that we are going wrong somewhere. And it's just something to be mindful of. These principles aren't law, but you should really always follow them unless there's a clear reason not to. So moving on to the key sections that you might come across in clinical practice. We're going to go through each of these in a bit more detail, but here's a kind of an overview of what's coming next. So starting with Section 2. The Section 2 allows for compulsory admission to hospital for assessment and treatment for somebody with a suspected mental disorder for up to 28 days. Section 2 is used when the diagnosis is not clear or you need to assess their risk further. So it allows you that period of assessment to decide whether they need a longer period of treatment in hospital or what that treatment might be. Again, you don't need a specific diagnosis for this, but you do have to think that somebody is suffering from a mental disorder. Practically speaking, to detain somebody under Section 2, you need 2 doctors and an approved mental health practitioner. So the approved mental health practitioner, or the AMP is how they're referred to, is somebody that has gone through specialist training in the Mental Health Act. Historically, they were often social workers by background, but they cannot be registered mental health nurses as well, and other disciplines. At least one of those doctors must be Section 12 approved, which again just means that they've done a specific course in mental health law. And preferably one doctor should know the patient from a prior acquaintance. That's not a necessity, but it is a preference. What happens is each of the doctors will write a medical recommendation that sets out why they think that the person should be detained under Section 2, and then the AMP is the one with the final decision-making power. So the AMP is the one that ultimately will detain the patient or not. And so you can have a situation where you have 2 independent doctors that will both agree and write medical recommendations to say that the person needs to be detained, and the AMP disagrees and feels that that's not necessary. In these situations, it's often because the AMP feels that there is a less restrictive alternative. So, for example, they've identified that the patient could be treated safely in the community instead of needing to come into hospital. Importantly, patients have rights when they're detained under the Mental Health Act. They have the right to appeal to a tribunal, which we'll talk about a little bit later. They have rights to access to an advocate as well, who can support them in their rights. Under Section 2, we can treat mental disorders without a patient's consent. What's important to note, though, is that you cannot treat physical health conditions under the Mental Health Act. So if somebody becomes physically unwell under a Section 2 and needs treatment for that and they're refusing, you can't treat them against their will under the Mental Health Act. And that would need to be done under the Mental Capacity Act, which we'll come on to a bit later. Just a note for some terminology that you might come across. The responsible clinician, or RC, is the senior clinician that kind of oversees the patient care. Practically speaking, this is usually the ward consultant. So we've talked a bit about what Section 2 looks like. How do we get to Section 2? So again, the Act sets out very specific criteria that a person must meet in order for them to be detained. And all of these criteria must be met. You can't just have one or two of them. And this is what the doctors would write in their medical recommendation. So the patient must have a mental disorder, which we've talked about earlier. So that's any broad range of things. The mental disorder must be of a nature and or degree that warrants detention. Now, what we mean by that, so the nature of the disorder talks about the diagnosis itself, if they have one, and the chronicity. So, for example, you might talk about the nature of schizophrenia being a relapsing, remitting illness that's a long-term condition. Perhaps you might comment on the fact that the patient tends to relapse when they stop taking their medication, and that might play into the nature argument. Degree is a bit more straightforward, and that is basically the severity of the current presentation, how unwell they are, and the risks that they pose. So once you're satisfied about the mental disorder, nature, and degree, you have to argue that detention is necessary for the patient's health or safety, or for the protection of others. And you don't need to meet all of those, but you need to say which one of those it's necessary for. You have to also argue that assessment can't be done safely or effectively on a voluntary basis or in a less restrictive option. So, for example, the patient could not be safely treated in the community. So moving on to Section 3. This has the same detention criteria as for Section 2. So you would use the same sort of arguments to decide why somebody would need to be detained under Section 3. It's very similar to Section 2. The main differences are that it's not an assessment section, so this is more for treatment. So you should have an established diagnosis if you're going to detain somebody on Section 3. Section 3 lasts for up to 6 months, and this is renewable. And similarly to Section 2, it requires a mental health act assessment where you would have your 2 doctors and your AMP. Practically speaking, what often happens with Section 3 is that you see this on an inpatient ward. A patient has been on a Section 2 for coming up to 28 days, and they're reaching the end of that section. You as a clinical team don't feel that they're well enough to be discharged from hospital yet. And so you would then apply for a Section 3. Because usually at this point you would have your diagnosis or what it is that you're treating in a clear treatment plan. And important to note, after 3 months, so whilst the Section 3 lasts for 6 months, after 3 months you do need scrutiny of your treatment plan by what's called a second opinion appointed doctor. And this is something that the clinical team will have to apply for. And this is effectively an independent doctor that comes and looks at all the medications and the treatment options that you're using, and ensures that these are being done effectively and appropriately. They can make recommendations or suggest changes if they feel they should. Discharge from Section 3, and the same for Section 2, can happen sort of at any point if the responsible clinician, so the consultant who's in charge, feels that the patient has improved. They can choose to discharge them from section. At that point, they would be allowed to leave hospital. There are other routes to discharge. So if a patient appeals to the tribunal, which we will come on to shortly, the tribunal could discharge the patient from their section. And for a Section 3 as well, the patient's nearest relative can also request discharge from section. Just a brief aside, this is not a section in the same way that Sections 2 or 3 are sections to keep somebody in hospital, but you might come across this in clinical practice. Section 17 is effectively a prescription for leave. So if you've got somebody in a hospital on a Section 2 or 3 and you feel that they should be allowed some leave from the ward, they need a Section 17 leave form, which the consultant would write, and that would have very clear conditions of the leave. So what date it is, what time, how often they're allowed to go, whether it's escorted or unescorted. Without this leave form, leaving the hospital would be considered AWOL, absent without leave, and is not lawful. Community treatment orders. Again, this is another sort of part of the Mental Health Act, not specific for like the detaining sections like 2 and 3. This is it's effectively a continuation or suspension of a Section 3 in the community. So This only applies to people who are in the community and only applies to people who have been treated on a Section 3. The idea of this is it enables people to be discharged from hospital perhaps a little bit sooner, because you can impose mandatory conditions on their discharge. Those conditions are often things such as making sure that the person engages with their community team, stipulating that they must comply with their medication, things like that. And what it allows you to do is that if those conditions are breached in the community, so if somebody stops taking their medications, you can recall them to hospital. So the idea is that you're trying to reduce sort of revolving door admissions. It's an incentive for patients to engage with their teams and continue their treatment in the community. And it also allows you to act on any sort of potential relapse indicators very early, perhaps earlier than you would if they were less monitored. This requires an AMP to assess as well. So as I said, if the person's mental state deteriorates, if their risk increases, or if they breach the conditions of their CTO, you have 72 hours to recall them to hospital. That doesn't necessarily mean that they will stay in hospital. So at this point, there would be an assessment, and if the CTO is revoked, then the patient will be back on a Section 3. Practical point for CTOs, if you are setting out medication compliance as an important condition of their CTO, it really helps if the patient is on a medication that can be monitored. So for example, if somebody's taking lithium, we can quite clearly say whether they are compliant with their lithium, because we can check their blood levels. It's much harder to do that with something like olanzapine, unless you're monitoring their compliance every single day, which is less likely in the community. Okay, moving on. Section 5.2 and 5.4, these are what we call emergency holding powers. These are for patients who are informal or voluntary patients. So these are patients that are not detained under Section 2 or 3, and they are patients that are in hospital. The idea of Section 5.2 and 5.4 is that you're buying time to allow a mental health act assessment to take place where you could consider the use of a 2 or 3. So they're slightly different, but the same sort of purpose. 5.2 would be done by a doctor, and this would last for up to 72 hours. A 5.4 is done by a nurse, a registered mental health nurse, and this lasts up to 6 hours. Again, both of these, the idea is to buy you time to organise that mental health act assessment. They allow you to stop a patient from leaving a ward if you believe that they are at immediate risk. They have a mental disorder, they're at immediate risk, and you don't have time to arrange a mental health act assessment at that point. So often this could be seen in a medical hospital if you have, for example, maybe a patient on a medical ward who's come in after a serious suicide attempt. They're currently there on a voluntary basis because they've agreed to be there. But perhaps you're called at 2 a.m. because they're asking to leave the ward and they won't engage with you to talk anymore. And you're really concerned that if they did leave the ward, they might be at risk of further harm to themselves or another suicide attempt. So in that position, you would put in place a 5.2. So this allows you to stop them from leaving the hospital and gives you time. You can't actually treat the patient for their mental disorder under the Section 5.2 or 5.4. You can treat them under the Mental Capacity Act. So if they did need treatment in this time, you can still do that. But these are holding powers rather than treatment sections. 135 and 136. I'll start with 136 because that's much more commonly seen. Both of these are police powers. So Section 136 gives the police the power to remove somebody from a public place to a place of safety for a mental health assessment. So the police might see somebody in public that they believe is suffering from a mental disorder and they believe to be putting themselves or other people at risk. They would then have to take that person to a place of safety. This lasts for 24 hours, and this allows, again, time for a mental health act assessment to take place. A 135 is very similar. So the police believe somebody to be suffering from a mental disorder, then there is serious risk involved. The difference is that a 135 is from a private residence. So the police have to obtain a warrant from court to allow them to enter the premises. So this is a bit more of a complicated process, but it is done in the community. Both of these, the police will take a person to a place of safety, and this is ideally a health-based place of safety, which is a sort of purpose-built assessment building, or a 136 suite, it's often called, where police take patients under 136 or 135. And this is where they will stay until a mental health act assessment has taken place. If there is no space in a place of safety, they might go to A&E or in a last resort police station, but that's not ideal. You can't treat people again under a 135 or 136. These are purely to buy you time so that they can have a proper assessment of their mental health. And the outcomes from the assessment tend to be either the patient is discharged and they're free to go, or they are then detained under a section 2 or 3 and admitted to hospital. So I touched on nearest relative earlier on. This is an important sort of legal concept set out in the Act. Slightly different from next of kin, which would just be sort of a nominated relative of a person. And this is actually like a specific legal hierarchy. I've listed the order here. So this would be sort of starting from the top, and if the person doesn't have that relative, then it would move down the ranks. The nearest relative has specific powers. With relation to the Act, they can, like I said, they can request discharge from a Section 3. They're entitled to information. They can be displaced by the court if it's felt that they are being unreasonable or not acting in the patient's best interests. So if a nearest relative requested a discharge from a Section 3 and this was felt to be not in the patient's best interest, you could actually go via court to displace that person. Not done very commonly, but it does happen. We touched on the powers of the nearest relative. They have the power to apply for detention. So if they're concerned about their relative, they can apply for a mental health act assessment. They have a right to be consulted, to request discharge for Section 3. They have a right to information, and also if there are tribunals, they can be involved in those. So what is a tribunal? So patients have a right to appeal their detention, and this is part of like I said, historically, when we would just lock people up for no real reason, they had no say in the matter. The appeals process allows us to have a much tighter scrutiny of when we are detaining patients. The tribunal is made up of a panel of people. So it's a judge, a medical member, and a lay person. You'll also have the patient and their solicitor. The onus here is not on the patient to prove that they should be discharged from the section, but actually on the medical team to show that the patient continues to meet the detention criteria. So effectively, they just have to go through each of the criteria that we've been through before to show to the panel that the patient does meet those criteria and does require to be continued to have treatment under the Mental Health Act. And at the end of this tribunal, the patient can be discharged from section if the tribunal does not feel that they meet the criteria. The tribunal panel could uphold the section and the treatment continues. And sometimes the panel can recommend certain treatment changes or things to be tried that maybe aren't being done at the moment. So we've touched on the key parts of the Mental Health Act. I'm just going to briefly finish on some parts of the Mental Capacity Act that I think are also relevant, and some of these overlap a little bit with the Mental Health Act. So Mental Capacity Act is something that we'll see much more commonly in medical hospitals, but it's also very relevant for mental health treatment. Mental Capacity Act is a legal framework for making decisions on behalf of adults, and here adults refer to over 16s, who lack capacity to make a specific decision at a specific time. And it's really important to note the specific decision, specific time part. You will probably, or you'll most definitely come across people who will ask you, does the patient have capacity? Or will kind of broadly say that a patient doesn't have capacity without saying what for. And you always need to think about capacity for what and when this was assessed. For example, somebody with dementia might have capacity to decide what to wear in the morning, but they might not have capacity to consent to a hip replacement. So it's really important that we think about this on a specific decision basis. There are 5 core principles to the Mental Capacity Act. We always assume that somebody has capacity to make their own decisions unless we prove otherwise. We must give people all possible support to make their own choices before we determine that they're not able to do so. An unwise or eccentric decision that we don't agree with doesn't automatically mean that somebody doesn't have capacity. They are allowed to make unwise decisions if they have capacity. It would be important to sort of question somebody's decision and maybe think about their capacity if they do make a decision that seems really unusual or not what you would expect, but you can't presume that it's not a capacitous decision. If somebody is deemed to lack capacity, we must always act in their best interests. And this means that we need to consider their past wishes, feelings, values, not just make the decision that we want for them. So this should be about making the decision that the person would have made if they did have capacity. And finally, similarly to the Mental Health Act, we must always try to use the least restrictive option where possible. So the capacity test is a two-stage test. And so a person would be deemed to lack capacity if, due to an impairment of their mind or brain, they can't understand, retain, use or weigh or communicate their decision. And as we said, it's decision specific and time specific. The Mental Capacity Act allows you to give treatment or care in the patient's best interests, and it allows you to use reasonable restraint if it's deemed to be necessary and proportionate. We must always follow any advanced decisions to refuse treatment. So if somebody has documented that they would not want this treatment in future, we have to follow that. And we also have to work with any lasting power of attorney or court of protection orders. It doesn't allow for treatment of a mental disorder against a person's will if they would meet criteria for detention under the Mental Health Act. So if we suspect that somebody has a mental disorder and we need to treat them, if they meet the criteria for the Mental Health Act, that would be the much better legal framework to use, and we should always do so in those cases. If someone lacks capacity, we're not able to kind of deprive them of their liberty or keep them somewhere against their will without legal safeguards. And we're going to come on to that next. Generally speaking, patients on a mental health ward will always be either under a section of the Mental Health Act, usually a 2 or a 3, or they'll be there informally or voluntarily. If somebody is there informally or voluntarily, we need to make sure that they have capacity to consent to that admission and capacity to consent to their treatment. And if we don't think that the person has capacity, we should be thinking about the legal framework with which to treat them. So for example, if somebody has catatonia and is very passively accepting admission, they're not saying that they want to leave, they're not trying to leave, they're sort of passively taking their medications, that can't really be considered a capacitous decision. And so we should be thinking about treating them under the Mental Health Act. And this is the reason for this would be so that we can ensure that their rights are protected. So deprivation of liberty safeguards I briefly mentioned. This is the legal framework that allows us to lawfully deprive somebody of their liberty if they lack capacity. This is realistically used much more in the community in care homes, but we do see it on hospital wards, particularly in elderly patients with dementia, and also we do see it sometimes on dementia wards in mental health psychiatric hospitals. The acid test, as we call it, is that the patient would not be free to leave if we tried to stop them. And what that means is that, again, often you might have a patient with dementia who is sort of lying placidly in bed. They're not trying to leave. They're not making any efforts to go. But if they were to try to leave, we would stop them. And if that rule applies, the patient should legally be under a DOLS. Again, this is to safeguard patients' rights when we are effectively restricting them of their liberty. And so this sets out sort of very clear guidance, makes sure that any deprivations are reviewed and are proportionate, and that we're not just, again, locking people up without any sort of attention to their human rights. So choosing the correct legal framework can seem a bit complicated at times. There is some overlap between these things. As we've talked about today, if somebody lacks capacity to make decisions about their mental health care, they're believed to have a mental disorder, and usually the Mental Health Act would be the most appropriate legal framework to treat that. Mental Capacity Act is often used more in terms of physical health, and in the context of mental health, it is used, again, with physical health. So if you have a patient on a mental health ward who becomes physically unwell and they are not consenting to treatment, or they're deemed to lack capacity, you would have to treat their physical health under the Mental Capacity Act. And DOLS is a part of the Mental Capacity Act that allows us to restrict patients of their liberty if it's deemed appropriate and necessary to do so. So we've talked a bit today about why we need the Mental Health Act. We've discussed the key sections of the Mental Health Act and when we would use each of these and why. And we've touched a little bit on the differences between the Mental Capacity Act, Mental Health Act, and deprivation of liberty safeguards. Thanks everyone for listening.
Thank you so much, Charlotte. If everyone could just leave some feedback, that would be really helpful. You'll also get a certificate for watching. Yeah, have a great evening. Thank you.